This is Alan Winter, and I have my colleague Charles Zelnick again this week. We're gonna talk about improving access by working on the inbox, which takes hours a day at the end of a physician's busy day and is an important problem that has contributed to burnout. And we're going to show how AI in medicine can actually help this. Charles, you remember the good old days.
Oh yeah, I remember them well. When I first went into practice, we were on paper charts, and I think I was probably on paper charts for 15 or 18 years out of my 40 years of practice experience. But I wanted to start with a story about my desk. So this is sort of what my desk would look like back when I was in practice in the 1980s. And a lot of the tasks that we currently do on the inbox in the EMR, they're the same tasks that we used to do when I was first in practice. And there are things like refilling prescriptions, taking calls from patients, taking calls from the pharmacist, reading consultation notes from our specialists about our patients, looking at hospital admission and discharge notes or notes from physical therapists. These are all the routine tasks that need to be completed by a physician who's doing primary care. And so at the end of my day, and actually during the day, a couple of times a day, I'd stop and I'd have a stack of charts like this that my nurse would put on my desk, and I'd go through them and say, you refill this, call this patient back, and you see this patient in the office, and kind of triage them very rapidly. But there was a problem with this that was a pretty significant problem almost everywhere you looked in medicine on the paper days, and that was, where was the chart? Oftentimes the chart was missing. You'd get a call from the patient, and we'd look all over the office to find out, was the chart in one of our colleagues' desks? Was it in the lab? Was it in the billing department because somebody had asked for records? And we'd have to search all over the place to find the chart. So when electronic health records came along, we were really pretty excited about that as being a way to not lose charts anymore. So everybody was pretty excited about this. We weren't going to have the charts lost. We were going to connect our electronic health records with everything else. And providers, physicians really said, I want it all. The more information I receive, the better I can find it and help coordinate the care and know what's going on with my patient. So we routed everything to come into the inbox for the physician to review. And this was a good thing maybe, and maybe not such a good thing. One of the things I liked about the paper records was they didn't come home with me. So I didn't have pajama time in the evening where I was going through messages still after eating dinner and instead of spending time with my family, being on the computer. And when I was on vacation, those charts didn't go in my suitcase with me. I could go on vacation and not have to worry about refilling prescriptions or taking care of issues that my patients had. The patients didn't call you up when you were on vacation back in those days.
But something happened, and all this got sort of complicated by additional administrative requirements that have really impacted physicians' efficiency. And that's what we're going to talk about today is how the administrative issues or administrivia has had a negative impact on access to healthcare. But we have an opportunity here because we can fix this with technology and policy as well, but we can reduce administrivia. One way is we talked about in the last session on AI-assisted documentation with ambient scribes. And we're going to use that same technology a bit in talking about the inbox. But the most important part is redesign of the office processes, because if you're not seeing the patients in a timely fashion, as we talked about last week on the failed workflow, then they're going to send a message to your inbox. Or if they can't get an appointment in the time you told them to come back, they're going to ask for a medicine refill. And if they don't get the care they needed, they're going to call up and ask for the nurse, and she may not be able to handle it. So your inbox is going to fill up. And that emphasizes the importance of office processes. Of course, the key may be automation of the inbox by triaging the things that are going into it to try to make it less of a burden. And we're going to look at that, as well as the AI generation of prior authorization letters, which you're going to see as a huge problem for physicians. They're called prior auths, in which the insurance company demands that you fill out forms to write a prescription or order a test or get a consultation. And it can, by having AI help with this, it's already impacting this horrible burden of prior authorizations. Finally, the chatbot can make repetitive messages for instructions that you give every day, like what to do for a cold and sore throat, and also how to keep up with your preventive items. We can see how that can help reduce the human needs of the inbox. So the inbox has changed, hasn't it, Charles?
Yes, and it's one of the areas that we really have pretty good metrics on, because the electronic health system tracks everything that you do. And what we see is that before the pandemic, this was already a problem going back to 2015, 16. We did realize that the inbox was becoming burdensome, and offices were making efforts to delegate some of the work, to have people help with the triage, to improve the assistant's ability to take care of things with automated or automatic scripting that would say, if you're calling in with a urinary tract infection, here's how your assistant can help you, take care of that without having it to come to the physician's attention until it's time to sign the prescription. So the time, which was in the blue line here, and the number of items was actually going down until the pandemic in 2020. And then after the pandemic hit, of course, we couldn't have patients in the office for a year or so. And the inbox items went up because people were using the telephone, they were using the portal to try to get the care that they needed when they couldn't come in. And since that time, both the number of messages and the number of minutes per day have continued to go up and stayed up despite continuing efforts to try to manage inbox by all kinds of systems, all kinds of offices across the country. So this has led us to an overwhelmed era where all of these items, these tasks, looking at diagnostic test results, reading consult notes, looking at your emergency room and hospital notes from your patients, doing the refills, and these administrative requests like prior authorizations and letters, and writing people's letters so they can have pets in their housing. All of these things go through the choke point of the physician, and the time has just gone way up. It's spilling into evenings and weekends, and it erodes work-life boundaries and drives stress and burnout. And one of the things that we need to think about in terms of moving forward is the first thing is to look at our own attitudes. And I showed the slide earlier with the doctor said, "I want everything," and we all did want that when we didn't really understand what we were asking for. But now the way to think about, can we get rid of some of this stuff coming to the doctor, is to think about how doctors think about each case. So if a prescription refill comes to my desk, or a message from a patient, or if I'm actually seeing the patient in the office, we recreate that patient case in our head anew. We make a new version of that patient case in our head each time we see the patient by reviewing the information in the chart, getting the current story, the updated story about what's happening with that patient, double checking that what we remember about that patient is true. Do they still work in the same place? Have they been through a divorce since they were last in? Checking out the chart data, updating it. Have they had new lab work done recently at the specialist office? And then pattern matching and decided what else do we need to know and what we should do. So the less outdated, wrong, or irrelevant data that you remember, the better your case formulation is going to be. And the bottom line here is you don't need to see every note that comes through about your patient before you're actually going to be recreating that case in your head. So for me to see a discharge summary today, and I'm not going to see the patient in the office or make any decisions about them till next week, it wastes time for me to have to do that twice. It's better for me to put that discharge summary aside, to file it away, and to let the visiting nurse send her notes in, to let the pharmacist, tell me what new prescriptions have been generated, to actually talk to that patient again with the discharge summary in front of me and build that case in my head right at the time I see them. And to have to look at everything twice or three times before you actually have to make a decision for the patient wastes a lot of cognitive power and really wears physicians out. So we don't want everything, and that's the first decision we need to make as providers is we can get by without everything, but we do need to have the important stuff. And so the question is, how do we sort that out? How do we get to that point?
Well, we have to break it down into what the items are and how long they take. And here's the first slide of the approximate share of the inbox that each of these items is taken up. And we're going to talk about those individually.
So this slide, to walk you through it, in blue is the 2018 share of the inbox, and in red is the 2026 share of the inbox. And I want to point out that this is organized with the things that take the most time for the doctor to do at the left. So you see prior authorization, insurance messages, these take 12 minutes per message, a long time in the office. And then patient portal messages, 5 minutes each, abnormal results, follow-up, 5 minutes each. Patient calls, 4 minutes, orders requiring signature, 4 minutes, medication refills, 2.5 minutes. And then way over on the right-hand side, the thing that takes the least amount of time is 3/4 of a minute for a system alert. And that's because providers pretty much just ignore all of them. So the change that we see that I want to point out between 2018, before the pandemic, and 2026 is that patient portal messages have gone from 20% of the inbox messages up to 34%, and phone calls have gone down. So the portal didn't get rid of phone calls. The phone calls went from 13 to 6% of tasks that had to come to the physician's attention, whereas you have 14% increase in patient portal messages. So the portal messages have really gone up quite a bit across the board. And then med refills and prior authorizations have also gone way up.
So if we break these down by minutes per day, we can see that prior authorization takes the most time. And the patient portal messages, again, are considered. But the part of this that's most difficult is this is totally unpaid pro bono work. Nobody pays for this. So, of course, administration doesn't want to give additional staff to help with it because nobody's paying for it. And it's a defect in the fee-for-service method of reimbursement, which we're going to address next week in our final session on physician burnout. But this is an important point. The end of the day, nobody wants to deal with all these items and their free work.
Right. The prior authorizations, 5 or 6 of those, and you've lost an hour of patient time.
So, exactly. So, how much can an AI agent do to help prior authorizations? Personally, that 12 minutes that it takes, I think we ought to give that to AI completely. An AI agent could have the prior authorization from the insurance company, which usually comes as a message, that could be uploaded into the AI agent. The AI agent could search the chart and generate a response to that message. Now, I don't think I have to review that. I think it needs to be sent on to the insurance company and see if the AI agent on their end accept it, or the high school kid that's reviewing it. And I don't care if it hallucinates or has some wrong information in it, because it's just a prior authorization. They're double checking me against what my judgment was to order that test. All I care about is getting that test ordered in satisfying the insurance company. There's nothing to do with patient care. So I would recommend that AI agents take care of all this.
But I think this is one thing administrators and doctors would all agree would be worth paying for to save that time.
Exactly. Then the patient portal messages. Well, I think I alluded to this. If you don't have a schedule that allows you to see the patients because your schedule is full for 3 months, then patients are going to be sending messages. I know my wife does this when she can't get in to see her physician, so she fills up the patient portal with messages that would have been money generating if the patient could have come in. And we've talked about the open schedule, which is the only solution to reduce the patient portal messages. Otherwise, somebody's going to have to take care of them and either have them come in or have some method of care for them, either through an e-visit or telemedicine. And the scheduling in the clinic is critical to handling this, and the portal messages could be converted using AI agents to visits, and I would recommend that.
And I did a televisit this week with somebody who sent a message into the free clinic and used AI Scribe while I was doing it, and it made my note perfectly done by the time we finished our 15-minute talk, and I will just paste it in the chart and be done with that visit. And if there wasn't a free clinic, that could have been billed as a telemedicine visit.
Perfect. Abnormal results. AI is not going to do anything for this. If you have abnormal results on a patient, you need to contact them. And I think this is critical from every doctor's position, but I want to talk about it from a safety standpoint. Having these results come at the end of the day with only a tired doctor reviewing them is the worst possible scenario. The reason that the tests aren't checked by the entity that completes the test, it befuddles me. I think if you do a mammogram, you should contact the patient and make sure they got the results from their doctor or notify them. The same with any piece of lab work. If a lab is doing doing lab work, they should notify the patient. If an EKG is abnormal, the cardiovascular department should contact the patient.
So anything that comes back abnormal really needs to go through a human in that loop and have some kind of explanation.
And this is why it's important. There's a high frequency of error. 30 to 36% of abnormal results are not communicated to the patients, which is why I think the entity that does the test, as well as the physician receiving the test, should both notify the patient. And otherwise, it leads to lawsuits, as we've seen. And I think in a previous discussion, I mentioned the $10 million lawsuit that resulted from the loss of an X-ray. In addition, there's a diagnostic impact. 32% of physicians lack a reliable method to track lab results, and that contributes to errors. In other words, we don't know whether the patient gets the test or not. Radiology and pathology risks report that 10% recommend follow-up, but only half are done. So this is another patient safety issue. And finally, the case studies reveal that 34% of malpractice payouts were due to diagnostic errors, most of which were lab and X-ray related, and 64% of malpractice claims are failure of diagnosis, including missed test results. So this is critical, that we somehow change the system to notify people of abnormal lab results.
How many offices still have a policy that the patient doesn't get notified of every result? And so the patients, they figure no news is good news. And I can't tell you how many people I've seen in the clinics who've said, well, I never knew that test was abnormal because no one ever contacted me.
Patient calls. We've talked about this. If you don't see them in a timely fashion because your schedule is bad, then it's going to result in patient calling. And these are non-visit care, and they should be changed to televisits, telemedicine visits, or e-visits, just as you just described with the other patient messages. Next are orders for signature. There's no way around this, that a physician needs to sign their orders. Medication refills. This is the bane of all practices. There's so many of them. I've seen practices that have as many as 70 a day, and this is incredibly onerous. What do you think the way we should reduce that, Charles?
Well, I think there's several things about this. One is it's a symptom of some office practices and office inefficiencies. So the first thing you should look at and say, are most of these refills coming in because the patient can't get into the office for their timely care, for their chronic illness care, to get their regular refills? And then are the providers in the office doing 3 months at a time with 4 refills for chronic medications? So blood pressure medications, the research is really strong. They should be refilled for a year, or otherwise your patient's going to miss out on medication and their risk goes up. So there are a lot of medications that are chronic that they should automatically be on 1-year refills, and the patient should be scheduled to come back in, have the refill done at the time they're in the office, so that you don't get a call in the first place.
We had a policy that each doctor would prescribe the medications for the period of time that he or she felt the patient could go without seeing them, plus another month. So that if, in the case of a controlled hypertensive, the refills would be refilled for 1 year. In the case of a patient that was on lithium, I was only comfortable treating them for 2 months without refilling the medicine. So I would give their refills for 2 months plus a month, so that I know by the 3rd month they absolutely have to be in. And so when they called, the receptionist would know, you need to see the doctor. By definition, you're a month past where he felt you could go before he needed to see you. So I'll schedule an appointment today, and you can come in tomorrow or the next day. If they were out of town, then we called in as many days as they needed until they came in, and they would be given the appointment. So all patients were seen, and the medication refill requests dramatically reduced. When you have lab and imaging results that are normal, what do?
Send the patient a letter saying it's normal. Yeah.
You send the patient a letter saying it's normal, and that's not something we have to do. AI could do that easily. Staff communications, well, we're still going to have to respond to staff telling us stuff. And finally, preventive care reminders. I think AI could do all of this. What do you think, Charles?
I think quality studies have shown that having AI systems that are calling patients or sending them letters reminding them to come in and get their colonoscopy or their colon cancer screening. These have mixed results. And basically, the less contact you have with a relationship when making those recommendations, the less likely the patient's going to do it. In other words, if they're sitting in front of me and I say, listen, you've got a family history of colon cancer, you really need to have a colonoscopy, you're much more likely to convince them to do it than if they get a letter in the mail that says you need to have this invasive procedure that they may not know that much about or may have misinformation about. So we can definitely have the AI reminding the patient, but there's going to need to be a human in the loop to figure out when the reminder doesn't work, if that patient's overdue, why is that? And do we want to keep readdressing that with the patient? Has the patient made a rational decision, for their own reasons that they don't want to do that? But this is definitely something that automation can help us with quite a bit.
And we can do it at the annual wellness visit. Administrative and system alerts, as you say, most of the time, these are easy.
I want to tell a story about that, administrative alerts. So this is a good example of how you set the system up can make a big difference. So we said that most providers ignore their system alerts. In my health system, a quality initiative was to improve blood pressure control on all the patients in the system. And so in their wisdom, the committee that was doing the quality work said, well, all of the patients are seeing specialists and they're in the hospital and they're in the emergency room. Every time we have a blood pressure that's too high, we're going to send a message to the primary care physician so that they know about it and can take care of it. And within a month, all of the primary care doctors' heads were blowing off because our inboxes were filled up with patients' blood pressure saying this blood pressure was high in the patient's office when they went to see the surgeon. Well, of course it was high. The surgeon was telling them they needed to have surgery for this condition, and they were nervous or upset or not settled down. But we would get all these alerts back in the system. So we turned that off. And I think it's really important. This is a really important area where when you're looking at how your system is set up, making sure that things that don't need to come to your inbox, things that you can't really do anything about until the patient comes back into the office, don't come into that inbox. And we need to all be advocating with our IT teams and with the committees that are setting up the rules in the system to make sure that that happens that way.
So what are the strategies we can do to lighten the inbox load? We've talked about system redesign. An open schedule would reduce the number of patient calls and messages. Certainly the team-based delegation of tasks where the human and the AI works together. The idea of pre-processing the results for the physician to look at, the same with refills. So many of the things in the inbox could be reduced. The reducing of irrelevant system-generated messages is critical. And as we said, all these consults and medicine discharges and other information that's not relevant at the time of day that we're seeing them could wait until the patient actually comes in for their visit. And finally, administrations have to realize that this free time is not free time to the physician, and it has to have some reimbursement by giving help to the physician to work on the inbox. Don't you agree, Charles?
I agree. I think protecting non-clinical time is really important. And we see in the research that the time is saved by using AI Scribe, so it doesn't take as long to document the note for the visit you just have. Providers are currently using that to try to weed out their inbox, and it's important that administrators and leaders not try to cram more patients into the schedule when the inboxes are still so full and there's still so much non reimbursed work that has to be done to take care of our patients.
So we can see how AI assisted messaging, triage, and getting rid of prior authorizations, as we mentioned, as well as filing of items that do not require action. And AI could assist in this very easily. So to sum it up, here's the future.
So where previously we had a huge bottleneck in the center of this slide where all the things were coming in and funneled directly to the physician, now we see an ideal human or AI inbox agent where the AI is helping look through the messages, look through the results, and make a suggestion, which is then routed to a human in the loop, either a nurse, an MA, or a pharmacist. Things that can be taken care of by the human and the AI combination. And these are things that need to be rule-based, like the prescription refills, and they need to be validated and checked for accuracy and safety. They should be taken care of and never really reach the physician's desktop. We want the physician to be seeing only what they need to see when they need it, with less noise, less things that aren't important, so that there's more focus and better cognitive addressing of the things that are in the inbox and more time for patients.
Charles, thank you for your help today. And next week, we'll talk about physician burnout.
Great.
Bye.
Thanks a lot. It was a pleasure.